Thank you so much. Please, you may kindly take the weight off your feet. Again, you're welcome to the one-day workshop, news conference, heralding, to explain rather the NHIS Act that was signed into law recently. Ladies and gentlemen, we'll take a few introductions and we'll start where we ought to start. We'll start with the chief host, the man of the moment who invited us here. You already know that his appointment letter carried within the weight of 10 directives handed down by Mr. President, and they included tasks that were previously considered impossible. Howbeit, by his second year in office, he had achieved all but one: to review the existing law, at that time, the NHIS law. It was clearly outside his powers to bring it to fruition. And so, but the journey to repeal that law did not begin with him. It started 23 years ago in 1999. Stakeholders had resolved that only a repeal would guarantee the acceleration towards the attainment of universal health coverage. All his predecessors gave him their best shot, but when this uncommon, authentic professor took office, a man of steel will, he pursued this objective like Nigeria's survival depended upon it. Deploying the policy of strategic engagement with his bosses at the ministry and at the National Assembly, he finally pulled the NHIS chestnut out of the fire. On Thursday, May 19, 2022, the President signed into law the NHIS Act. You may wish to note that that document was not an executive bill, and so you can imagine the Herculean task that it was. A little wonder, Providers Association gave him the highest honor, Semper Fidelis, a consistent fellow in the national cause. Ladies and gentlemen, please join me to welcome the first Director General of the National Health Insurance, Professor M.N. Sabo. Also in the room are members of top management to support the DG. In no particular order, please. We have the General Manager, Human Resources and Management, Alhaji Sani Garba. We also have the General Manager, Media and Public Relations, Chief N.A. Arnold. General Manager, Internal Audit, Mr. Kayode Inspire. General Manager, Finance and Accounts, Mr. John Gilbert Oko. And the General Manager, Legal Services Unit, Barrister Blessing Nege. The General Manager, Planning, Research and Statistics, Haja Asma Mohammed. And Acting General Manager, Informal Sector Department, Dr. Siku Salaudi. General Manager, Special, my boss, Mr. Ayo Zilu. And also the Acting General Manager, Procurement Department, Pastor James Balani. You're all welcome. I hope I didn't miss out anyone. Oh, sorry, the Gentle Giants. I didn't cite you, sir. The General Manager, Standards and Quality Assurance, Dr. Yakubu Amada. Thank you. Thank you. Ladies and gentlemen, without taking so much of our time, we'll invite the Director General of the National Health Insurance Authority, the irrepressible, the unstoppable, the indefatigable, Professor M.N. Sabo, for his keynote address. Please put your hands together as the DG necessary to the program. The Director General says we should have an introduction of our colleagues from the media who are here with us. So please kindly introduce yourself. So, okay.
All right. Good morning, everyone. DG, good morning, sir, and good morning, Your Excellencies. My name is Moses Amorinken, and I write for the National Newspaper. Thank you.
Good morning. Good morning, all. My name is Kavu Durio. I work for the Nigerian Student Society.
Good morning, everyone.
Good morning, everyone. My name is Solomon and I work with
Good morning, all. My name is Obon from NHIS. Good morning, all. My name is Patience Niejirika from Leadership Newspaper.
Good morning, all. My name is Fred. I work with the Senior Team.
Good morning, all. My name is Ishima Piaiwa. I report for Hot FM.
Good morning, all. I write for Business Leader.
Tony Adebayo, Daily Independent Newspaper. Good morning.
Good morning, all. Franco Philomene Zola.
Good morning, all. The show is Ghana.
Good morning, my name is Udupe and Captain.
Good morning, sirs. My name is Gloria Sia, Voice of Nigeria.
If you recall, 3 months ago, precisely April 26, I addressed the World News Conference. On that occasion, I presented a scorecard of my leadership and concerted effort being made to bring affordable and quality healthcare for all Nigerians. At that time, all but one directive handed down by the President Muhammadu Buhari upon my appointment had been fulfilled. We have had several engagements with media. We have enumerated all the 10 points deliverables I was handed over to and called on value orientation, transparency and accountability, as well as accelerating the drive towards attainment of universal health coverage. We were able to deconstruct all the transparency and accountability and 2 key elements in our quest to attain universal health coverage. And we saw into action to see that we implement those elements to achieve all the mandates that we have been given by the President. Today, I am delighted to announce to you that the outstanding presidential point has been brought into fruition. The National Health Insurance Act, National Health Insurance Authority Act. Let me say that when the first law establishing the national health insurance was promulgated in the year 1999, it was identified or it was recognized that there is a heavy lacuna which will not facilitate the attainment of universal health coverage because the law was not made mandatory. And there is no way any country can be able to attain universal health coverage. Facilitate 2 things. One, it will compel all people that have ability to pay for health insurance to join the health insurance system. Secondly, it will put burden on the government to source for resources to cover for the poor. That is what that mandatory bill will achieve. And I'm glad to say that the National Health Insurance Authority Act is made mandatory. Therefore, it will be able to achieve these two cardinal things that mandatory law can achieve. During our implementation of the three-point agenda, we have interacted with so many stakeholders, and I can't even remember how many times we have engaged with the media, all in an attempt to deepen understanding of what health insurance is and what are the obligations and responsibility of every stakeholder. And to a large extent, we have been able to succeed in that area. Stakeholders were agreed that during our conversation, all the stakeholders have agreed that we should have insurance in Nigeria fundamentally reset the ecosystem. It changes the name of the agency from the National Health Insurance Scheme to the National Health Insurance Authority. From the moment Mr. President put pen on paper, health insurance became mandatory. The NHIA Act empowers the authority to see to it that all Nigerians and legal residents have access to health insurance. This is a complete departure from the previous law, which made health insurance scheme optional. The new authority will coexist with the state system and other stakeholders. What this means is that if you look at the National Health Insurance, the repealed act, there was no any mention of state health insurance. It was designed to be an omnibus health insurance system without participation of the states. But this new law has legitimized the existence of all the state health insurance agencies, and therefore now we have the National Health Insurance Authority at the center and 36 plus FCT health insurance agencies. All are going to coexist to provide the needed health insurance for every Nigerian. And it is heartwarming to note that as if we are aware that one day this health insurance at the state level will be legitimized, we unpacked the health insurance under our agenda and the strategy to ensure that although the health insurance is being implemented in a decentralized manner, but there is a very credible framework to ensure effective coordination. The technical working group on that health insurance under our has been working, and we are already integrating all the aspects of the health insurance so that it will be decentralized, but it will be working towards a common purpose. Significantly, the law has made provision for the establishment of what is called vulnerable group fund and outline the sources of the fund for it. This is one of the major achievements of the law. The Lancet Commission has done a very extensive study which was published in the Lancet. Lancet is the highest medical publication journal that you can publish, and a particular session was dedicated to transforming healthcare delivery system in Nigeria. That Lancet Commission report, which was launched by the Vice President some months back, had compelling recommendations, and one of the recommendations is to ensure that the country establish this vulnerable group fund to cover for 83 million downtrodden Nigeria who don't have access to 3 square meals, so that they can have access to the healthcare delivery system. And I'm glad to inform you, at the point when Mr. President was signing that law, he made a pledge that Nigeria and his government will make provision for the 83 million vulnerable segment of population to to be covered under the social health insurance. And this is one of the potency of the mandatory bill. You didn't clap, Mr. President. I don't think if government has ever signed any progressive law that will touch life of all of Nigerians like this mandatory social health insurance law. Therefore, this establishment of the vulnerable group funds has outlined various sources of funding of this vulnerable group. And unfortunately, you will not be able to see the telecom tax, which we have been talking for a very long time. The initial bill before it was regulated to ensure that the fund for the vulnerable is generated. But we were advised by the Ministry of Finance that NHIA or NHIS then was not a revenue collecting agency. Therefore, they cannot make that provision within the law. Therefore, we have to go back to the National Assembly, and that clause is removed, but is substituted with what is called telecommunication tax. That telecommunication tax will be defined whenever there is need in the Financial Act. For example, very recently, government has approved tax, and NHIA is making a very strong case that tax that will be accrued from SSB should be channeled to the National Health Insurance Scheme for the purpose of coverage of the vulnerable segment of the population. And that does not even push away our quest for that telecommunication tax. We will still go and pursue the telecommunication tax and ensure that it is encapsulated in the Financial Act of the government, so that whatever policy that is accrued from there can come to the National Insurance Scheme. Distinguished esteemed guests, I want to tell you that with the repeal of the NHIS law, the name of the agency has now been changed to National Health Insurance Authority. Henceforth, any communication with us should contain National Health Insurance Authority, not National Health Insurance Scheme. More so, the nomenclature of the Chief Executive Officer of the organization has been changed as well. From what we used to know, the Executive Secretary, to now Director General. Some modifications have also been made in the content of the governing council of the authority to ensure that people that are being regulated are not part of the board. One are not part of the council. One of the positive of the other of the law, it made a provision in the governing council. The people or the group of people that are supposed to be regulated, they are part and parcel of the board, and therefore they always have a due influence out from the organization. Now, with the removal of those people in the board, we now have a situation whereby NHIA will play a very active role of promoter. The law was passed on the 19th May. We very well know that the law cannot implement itself. Therefore, people will have to understand the law, and people have to have a deep understanding of the law, and then we now begin to develop strategies to ensure its implementation. To that effect, we began with a 3-day retreat in Abuja, where all the expanded management of the bank discussed every element as contained in the new law. And from there, we went into meeting stakeholders in order to enlighten them to appreciate this new law. And what we are doing, the exercise we are doing, is part of the collective engagement to ensure that media that is supposed to be reporting the events are very well conversant with the new act, so that whenever they are reporting, they report it correctly. And this is when the president assented to the bill. There was a media that carried the fact that another tax has been slammed on Nigeria. This kind of reporting should not be. The thing that is supposed to be is for the people, for all the media people to be in this kind of gathering and get right and accurate information about the bill, so that it can be reported correctly. We have engaged several stakeholders at national and sub-national level. We have engaged with the commissioners of health. We have engaged with state health insurance agencies. We have engaged with the international developmental partners, and by tomorrow we shall be engaging the healthcare providers. And within the week, we are going to also please permit me to state that this workshop is being held in recognition of the implicit capacity of the media for information, education, communication, as well as advocacy. There is no way we can succeed as an agency of the government or any agency of the government without carrying the media along. And this program that we are running, National Insurance Program, it is a program that it will help and assist all and sundry. Insurance business are those people subsidization. How do you aggregate resources to cross-subsidize for people that are poor, for people that cannot afford to pay? Immediately after this consultation, we will embark on another critical adventure, which has to do with development of strategic development of strategy for implementation. It will entail development of or upgrading of the guideline to ensure that the content of the law is clearly spelled out, so that every actor that is going to work within the health insurance ecosystem has a very good understanding, a deep understanding of the content of the law. Ladies and gentlemen, may I add that the importance of this act is further underscored by the recent visit of high-level mission from World Health Organization to our agency. Throughout last week, we were hosting a high contingent, a very high level contingent from Geneva WHO headquarters and from Brazzaville, African region of WHO. Why were they in Nigeria? Because they have learned that Nigeria has signed a mandatory law for health insurance. And one of the critical things that the WHO tried to look at, if you are in the right trajectory of attainment of universal health coverage, is the presence of mandatory law for social insurance. So when the WHO learned that we have signed this, President has signed this act, they called us and we had a Zoom meeting where I made a presentation to them. You know, sometimes these people, when you make a presentation remotely, they will not be able to confirm. So there and then, after the Zoom meeting, they asked all the members of the WHO to stay back. And after they stayed back, they came with information that they have set out to come to Nigeria to come and see for themselves. And for the first, throughout last week, they came, we made a series of presentations to them, and we took them around to see policy makers, Secretary to the Government of the Federation, Director General Budget, Minister of Finance, and host of other stakeholders who can, the purpose of their coming, one was to thank the government for being able to sign this bill. Second, to encourage the government to put all necessary machinery in place for the implementation of that bill. including making adequate budgetary provision for the coverage of the vulnerable. And the group of our esteemed guests were very happy with what they saw at us, so that if we have any doubt, if we have any question, at the end of the day, we ask the question and we go back well informed. So ladies and gentlemen, let me use this opportunity to welcome you all for this very important occasion. And I hope we will have a very fruitful discussion, and at the end of the day, everybody will go back to his office safely. I thank you very much for listening.
NHIA makes it compulsory, makes health insurance compulsory. We know that many civil servants are already in the NHIS, but with this mandatory health insurance now, how do you compare those that are not in civil service, maybe are in the streets, working or selling in the markets? How are they going to be, integrated into the mandatory health insurance?
Okay, my name is Moses Samuel, the Stakeholder. And just to follow up on what my colleague has said, I would like to also know, it's one thing to get the law rolling out, it's another thing to implement. So do we have like a window period? I know you said there's going to be engagement to stakeholders, but do we have like a window when implementation, full-time execution will begin? That's number one. And number two, it's interesting that we have the vulnerable group fund, and fine, we know that some of it will come from the basic health care provision fund for selecting the indigent. I can claim on and who does that? Who does that? Thank you.
My question, Uche from NHIA. I believe that the law also has some provision for expansion of certain ailments that are covered by the NHIA. So I want to believe ailments like cancer, which before now are not covered, are there any provision for them? Secondly, what are you going to do about the delays in some hospitals? When you visit some hospitals, especially when you go to the NHIA section, you'll be told, call your HMO for this or for that, and all these protocols take time, especially people that are in their need of services. What are you going to do differently now?
Sorry, DG, it's one of my questions very quickly. Now, there is a point where we know that the NHIA is supposed to be an insurer. That's one of its functions. And so it's going to be playing like the NHIS that we know, probably the CBN, to ensure that now, but my question now is this. In the NDIC, for example, you have capitalization benchmarks. Now, but now when you talk about HMOs, those that are providing healthcare, now they are going to be on in case they get into some kind of problems. Thank you.
Yes, with the signing of the new NHIA Act, I imagine that the issue of the campaign on gift ship insurance platform will be very appropriately deployed. How is the organization taking steps to utilize this to cover more?
Did you mention that the one Kobo seconded telecoms charge has been replaced with a telecommunication tax? If I got you right. So can you throw more light into this? Who is going to bear the funds of this charge? Is it going to be transferred to Nigerians? Because I know that as of 2 days ago, the federal government said that introducing a 5% tax, which even the Ministry of Communications is now kicking against. So they said that Nigerians are paying too much. So I don't know, this telecom tax, is it the telecom operators that will bear the funds, or is this something that I don't know how to be able to achieve this? Thank you.
Good morning once again, sir. My name is Gloria Sen from Voice of Nigeria. Recently, as recently as last week, a group of experts from WHO in Nigeria to deliberate to the NHIA. I want to know what was the deliberations about and what does Nigeria stand to gain from that meeting. Thank you, sir.
Good morning, sir. My name is Philip. I work with the Sun Musicals. So this is in the course of your speech, I did hear you mention HA people, and they are very key in your activities or health insurance services. Now I want to know in the new act, where additional responsibility given to them, or are they still maintaining what the role they play in this particular existing or the previous stuff? And so I don't completely sure. Let me know just this one.
My name is Patience from Leadership Newspaper. Sir, some people have health insurance, they end up spending out of pocket to purchase drugs due to stockouts. So, I don't know how soon the NHIS branded drugs will be out.
That's awesome.
Let me confess that the media is now our friend. The media is now our friend. These are very good questions, very relevant to health insurance. If it was before, the kind of question that because all these questions are very direct and relevant to the health insurance. So thank for this question. For especially people that are in informal groups, traders and so on and so forth. When Dr. Emmanuel, you are a doctor, when I was conferred with investiture in Lagos of some Fidelis Awards, I was interacting with the Commissioner of Health in Lagos. He said that since 2015, they have been trying to see how this law, their own state law, can be amended to be compulsory. But to no avail. Because even this law, it took us 23 years to get it amended that we see. So I told the commissioner that this law, this new NHIA law, has already made health insurance compulsory. All you need to do in Lagos is how do you implement it. He's within the ear of Lagos. You will be compelled to join health insurance. So how will that be achieved? There are so many strategies to achieve that. Number one, those who are public sector, they are already in it. And organized private sector, some are in it, some are not in it already. So they will be compared because you cannot do business in Lagos or you cannot do business in Nigeria provided you are a health insurance. How do you protect your workers health-wise? The other strategy that we intend to employ is persuasion. How do you pursue people to see the value, to see the merit If he has health insurance, he will not leave. Because he has worked and he has seen the benefit of it. So health insurance normally markets itself by the kind of services inform and educate people aggressively. And by the time they see that it is protecting them, they will really come into it. For other informal sectors that are having resources, but they are unwilling, government will bring policy. If you want to register your education, if you want to register your child in the school, you must show evidence that you have health insurance for him. Because there is no point you take your child to school, but when he is sick, we are going to talk with relevant authority evidence of health insurance. Is for us to go and take inventory of all the people that are, all the children that have evidence of health insurance. There are so many ways to do it. I cannot take my child to school. Because one of the aim of the health insurance is to abolish out-of-pocket expenditure, which is very, very cruel system. And one of the objectives of the health financing globally is to ensure that out-of-pocket expenditure is significantly reduced to the level of below 15% of the total population. So what we are doing is trying to protect people so that they can be healthy, they can have quality of life, and they can have a productive home, and they can have a productive community, and we can have a productive Nigeria. And this is where the media will help us. Because I say we are going to do it through information persuasion. Answer to me. Say it to the something so that everybody will hear. So the work is now on you, it's not on NHIS. The aspect of persuasion, the aspect of information, the aspect of education, it is your responsibility. All we can do is to facilitate you to do your roles. It's not to do a negative reporting, but to do a positive reporting. And the best positive reporting that you can do is to tell people that they should be well. So it's not how is NHIS going to do it. It's how we are all going to do it to ensure that everybody is in the health insurance ecosystem. Have I made my point? Good. Number one, window period for full-blown implementation. For now, as I'm talking, we are making consultations. And when you are talking about full-blown implementation, you are talking, we have started full-blown implementation. So we are not going to be fixated, but we are dialoguing, we are educating as first step, then we start dialoguing, then we start meeting the relevant structures that will make some laws that will govern this seamless implementation. For example, who is responsible, like the Secretary to the Government of the Federation will bring a circular that will say every public sector will have to PEMCO. Which one is more important? Health or pension? Which one is more important? So if PEMCO is made to be part of it, that of health will be very, very much easy. Because once you have healthcare protection, I think some of you should do a reporting or a deep research. I'm challenging the media to do a deep research on the contribution of ill health to poverty. How into poverty. And when we are talking about financial risk protection, is to what extent you have policies that will protect people from getting into poverty as a result of ill health. Please take this as a challenge. When you have this information that will give a financial risk protection to people. So we are going to meet all these relevant organizations to ensure that enabling laws are put in place for seamless implementation. So at this level, it is a milestone. And I cannot tell you in 1 month or 2 months. And there are other far-reaching reforms that we need to undertake within the organization. I'm going to allude to them when I come to respond to other questions. So it's a work in progress. By the time we finish with consultation, by the time we finish reaching out, we will be able to provide a very detailed implementation strategy with clearly defined dates. But at this time, we are trying to consult. We are trying to get people to internalize. One of the major problems, and this time around, we don't want to fall into that situation. We want to ensure that as we are reading, we have a very clearly defined strategy of implementation. And number one strategy for implementation is for people to appreciate what the law says and what is my role and what is my obligation. Number three, what is the criteria for assessment of the vulnerables? I'm a public health, I'm a professor of public health. The difference between a clinical doctor and a public health physician is that while the clinical doctor is concerned about curative care and determinants of disease in a community. So every year we take final year medical students to go and clerk communities. When a patient comes to a hospital, he is clerked. What is your problem? Presenting complaint, cough, for how long, for this thing. That's a clerking in hospital setting. The public health physician, we go to communities, we clerk the community. What are the barriers of environmental health? We look at the social that are inimical to health, and we have a comprehensive picture of the community and all the determinants of the disease in the community. One of the most difficult things to ascertain is income. When you are doing community diagnosis, it's income. People find it very difficult to divulge their income. The person that asks this question, if you have a wife in labor and she is working, and you if you are clever, you will divulge your salary to her. So in a developed society, one of the very difficult issues that you can to elicit is we are happy that the office of the Vice President has has developed what is called National Social Register, which has thoroughly gone through all the states and identified people that are poor and they are in that register. That is our planning to do, is to be able to utilize that register. But because the program is going to be implemented at the state level, we will ask the state to ensure that at the point of capturing people into the National Health Insurance Scheme, that data is validated. Because as a government, we have to have synergy, we have to be working together. So we are intending to utilize the social register after validation to deploy the implementation of the vulnerable group fund. And let me say that I'm sure you all know what is basic healthcare provision fund. Nobody should tell me that he doesn't know what is basic healthcare provision fund. So the mechanism for implementation of basic healthcare provision vulnerable group fund will be exactly through that mechanism that you do for basic healthcare provision fund. In other words, we are going to utilize state structures to deliver this through close monitoring and facilitated by ICT system. And we are all aware we have developed an over-aching ICT infrastructure, second to none in Africa, which is going to be ISO certified. And by the time it's, in fact, one of the things that WHO people that came for visitation, they have seen, they were wondering how we are able to develop that infrastructure. In fact, one of the things that we need media to do, we are planning to commission that infrastructure. And we want, Mr. President, because we obtained Federal Executive Council approval for that, to do that. We have written to the Honorable Minister that we are going to do a National Health Insurance Summit, and the entry point to that summit is presidential launch of the ICT infrastructure that we have developed. In fact, what we have developed is a revolution. It's not mere development of something. It's revolution in the healthcare delivery system. So we are going to utilize this mechanism to ensure that we have registered, the people that are registered are close to being the truth, because it's very difficult sociologically to determine the income. If you are in a developed countries, I've gone to Turkey, I've seen how Turkey has been able to utilize their NIM, national identification, as an entry point to every developmental issue that everybody is going to do. So everything of yours is tracked. Your income is known. So once you come to do health insurance, they will just put you on income test, because they know all your properties, they know everything. Then the income test will show that you are below the income test. Then you are under subsidy program. And once you are up there, you have to pay. So it's a gradual process. Expansion. I'm not happy with this question. While I'm generally happy with the questions, but I'm not happy to say that cancer up to today is excluded in health insurance. In the last meeting we had, I told you we have got into partnership with Roche, and Roche has reduced the cost of anti-cancer by 50%. And the remaining 50%, NHIA will pay the 30%. Then 20% will be paid by the patient. And I have even told you the states, the teaching hospital, that we have started piloting the program. So for this question to say that NHIS is not covering cancer is not acceptable to me. Having done a world press conference and we have told the world that we have this partnership and we are covering cancer. However, there could be some exemptions, but not cancer. For those exemptions, we will work to ensure that they are covered. But there is one rule of health insurance that I told you. As a media, you should not forget this rule. That rule is services in NHIS or health insurance is purchased. How is it purchased? Based on the money you have aggregated. If you require 10,000 to have comprehensive package as a health insurance industry, but you have done everything possible within your best ability, and you are only able to get 5,000. Can you get cover for 100%? I'm asking a question. You cannot get cover for that 10,000 naira. So health insurance, we aggregate money for people. And when we aggregate, there is a benefit package. This benefit package, it can increase and it can decrease depending on how much is contributed. The ideal thing is to cover 100%. But where you cannot cover 100%, you aim at covering basic healthcare package. In fact, even in all the health developmental documents, you will see that the concept is, what is the minimum healthcare package? What is the basic minimum package? What are the essential service package? This is the question. And if a country is able to cover essential package, I think that country is good enough. Because what is happening with respect to ill health, let me tell you. If you have a health challenge, it will start as a simple case. If you don't have health insurance, you will wait until when the thing has blossomed before you seek for care. But if you have health insurance, the moment you have a small health challenge, you will go to healthcare facility, you have access, and it will be taken care of at the onset. And therefore, when you are faithful in provision of the basic healthcare services, most of the people will not wait for their condition to reach a critical level that they will go to the hospital to seek for care. And that's one of the appealing features of the health insurance. If I don't have health insurance, if I have a health challenge, I will try and be managing. Go to chemist, buy a drug, whether that drug is going to work or not. That's what is called coping mechanism. You will not wait for that time. That does not mean emergency and high-level cases will not come. And if those emergencies are around, because by provision of the basic minimum package, you have been able to reduce the likelihood of having bigger cases. Let me give you a hypothetical example. If you are under health insurance and you are receiving medical examination, for example, you introduce a pap smear, pick a woman that is likely going to have a cervical cancer, and you do a screening program through pap smear, and those studies have shown evidence of likely having cervical cancer, you quickly take care of them. But if you don't have health insurance, and a woman, she will have some discharge, she will have some pain, and so on and so forth, she might not probably go to hospital until when it becomes advanced. And when it becomes advanced, it is there you are now confronted with a very serious challenge of having to treat a cancer through various means, chemotherapy, radiotherapy, and so on and so forth. Health insurance has ability to organize people. And the mere fact that people have health insurance and they have access to basic health care, they have opportunities to be able to be detected early and get services. So when health insurance will run a very long course, you will realize that the prevalence of diseases in human population will go down. Or the prevalence of the likelihood of coming late with healthcare condition will go down. I hope I'm making a point. Good. So, other things that can occur, because the health insurance has been able to reduce the instances very much, you can be able to factor in those diseases within the health insurance scheme without those who have escaped. You can be able to take care of them within the healthcare insurance fund. But at the initial stage, we are doing the basic provision of the basic healthcare. And incidentally, the basic healthcare services under the National Insurance Benefit Package is very comprehensive, it's very robust. Okay? Then delay in hospital, what are you going to do differently? In fact, we have come up with a very advanced mechanism of addressing this problem. We are about to deploy it, but we realize that effective deployment will be when we have a digital system, whereby you have a call system management, you can get a call from healthcare facility, it can go to our state, we have employed healthcare. The reason why, let me tell you the reason why that was not possible in health insurance that I met. In the entire health insurance, in NHIS then, there were only 43 healthcare professionals. Doctors, nurses, medical lab, and so on and so forth. And if you take northern states, north central, northeast, northwest, there was only one nurse in Kaduna. If an Erori has a problem in Bauchi, who will bail them out? So I met health insurance agency with a very serious fundamental structural issues, which for this years we have been addressing. And that is why we now employ about 200 medical personnel, 5 in every state, 2 doctors, 1 nurse, 1 medical lab, 1 pharmacist. In every of our state office, we now employ them. You know the process of recruitment in Nigeria. It took us so long to get clearance and so on and so forth to be able to do that employment. There was no way you can be able to check all those things that are happening. You don't have ICT, you don't have healthcare professionals. If there is a complaint in Yanagua, the complaint, they will write it directly to the headquarters. And when it comes to headquarters, almost all the healthcare professionals have a particular problem. How can that be possible? All the issue that has to do with authorization. Somebody is looking for authorization. HMO is the one that is providing authorization. And he will spend 24 hours without getting authorization. Nobody will give you authorization. Nobody has capacity to give you authorization at the state level. So those are fundamental structural defects that I made in the health insurance, which we have been working to correct. Now we have the healthcare professionals, we have trained them, we are redefining the business processes of the health insurance to ensure that every complaint I'm going to talk something sensitive, but I don't want it to be after all this discussion, and that is what I'm going to say on the heading of the newspaper. After all this educative lecture, I don't want. Yeah? So I should not say it. Yeah? No, I want it's part of what we are going to drive. Yeah? What? You see, if it is going to be mentioned, if it's going to be mentioned in a mature manner, in unsensational manner, I don't have any problem because it is provided in the law. It's provided in the law. Whether I say it, whether if I have not said it, it will come out. But the way it's going to be reported is the way that can shape the opinion of the people. I want to extract your listing. The law has redefined the function of HMOs. The law has redefined the function of HMOs. What is the definition? The NHIA and state health insurance will be deriving the provision of the basic healthcare package. Whereas HMOs will be providing the 2 roles or 3 roles. One, any health insurance beyond basic healthcare services is going to be delivered by HMOs. That is number 1. 2, this law has recognized the existence of private health insurance. So any private health insurance, HMO can drive it. Thirdly, HMO can also register to perform what is called TPA, third party administrator. What is a third party administrator? If you go to Bangkok, they have a very big call center management office. That call center management office in Bangkok is leased to private sector. So HMO can be a third party administrator within the national health insurance system. For example, we can say that this guy has a robust system of claims management, and we can hire him to do a claims management for NHIA. Am I making a point? But provision of the basic healthcare provision fund and the basic minimum healthcare service package is NHIS that will drive, NHIA that will drive it, and the state health insurance agencies. If you don't understand, ask me before you go and. Is that clear? Is that clear? Is that clear? What is not clear? The NHIA. You ask the question. The HMO. NHMO was controlling everything before. All the monies will go to HMOs and go directly from health insurance, NHIA, to the healthcare facilities. Not to HMO, for the basic healthcare services. But if a company or a big organization, public organization, they say they want a comprehensive package, NHIA will take money for provision of comprehensive package. And whatever is for supplementing, NHIA will send that money to the HMO of choice of that organization. Is that clear? Because we look at and let me say it clearly, this bill, because this act is not NHIA act, it's a parliament act. It is Senate Committee on Health that work on it. So we also saw it like that. But as an implementing organization, we'll have to work to ensure that we implement it as it is. Letters and spirit. But we know that it will create some disruption. That's why we have to manage it in a manner that will not bring any discomfort in the ecosystem. Am I clear? Am I clear? Excellent. The next, so because the role of HMO has been reduced with respect to the provision of the basic minimum package, the equalization, the risk equalization and capitalization is when it occurs. Because NHIA is a regulator, they will ensure that appropriate thing is done with respect to that capitalization. Okay? My very good friend has asked about gift sheet. How can we deploy the gift sheet program? The gift sheet is an innovative created to be able to provide platform for informal sector.
And with the mandatory bill, you will have more informal sector group coming into the health insurance. So states to also develop gift sheet to cover informal sector group within their states. In fact, what we are even talking about is over a period of time, they have competence to do that. So we want them to start while we are supervising them and ensure that they are doing the right thing. Then we will now begin to allow the gift sheet to the state to drive the gift sheet program in the spirit of health insurance under our roof. Then telecommunication tax, madam. Globally, the easiest way, globally. You see this GSM? If you conduct a study of how GSM has impoverished people, the finding will be very, very revealing. There are studies that have been conducted and found out that people spend more funds on the food they eat. So now, because people have spent all their monies in GSM and they are now sick, they cannot afford health care. NHIA is saying, for every call you do, you will take 1 kobo per second and keep it for you. So that we can aggregate so much funds to cover for the poor. If 1 kobo, when else did you see 10 kobo, madam, as a denominator? Since time immemorial. So that 1 kobo, anybody who said that 1 kobo per second will impose burden of tax to everybody, I think that man should go to Stone Age. 1 kobo for 1 second call, you would think 1 kobo is deducted. Because people are spending huge amount of money and therefore they are not investing for health. Now countries are saying, look, we cannot be that irresponsible for not helping our people to take a kobo from them and keep, so that people that cannot afford health care can utilize that money. Because of the numerous costs that is coming, that 1 kobo, if you put them with what is called power of economics, should help me. Aggregation. Kobo is dropping. Cumulatively, you will see you have billions. So please, media, help us in disseminating the right message. That cannot affect a household. And let me correct it. We put it, and the senators put it in the bill, but there was observation by finance. So they say it has to be removed. So it was removed. That does not mean it's not going to be revisited. That if NHIA is desirous of that, they can only advocate it to be included in the Financial Act. So if it is agreed, it will be put there. And nothing has substituted that one. But while we are having that conversation, we realize that government has already has introduced this SSB tax. Why is government imposing that tax? The reason why government is imposing that tax is to protect people. If you have easy access to all this sugar, there is a rising prevalence of non-communicable diseases, especially diabetes mellitus. And these are the issues that are pushing people into diabetes. Then government introduced and said that it can lower the consumption. And when it lowers the consumption, you have the money. That money to broad consumption, bring it to NHIA. Because when people are sick, they will go NHIA. And all of you should be champion of NHIS or NHIA from today. Because I'm not supposed to make this with this question and answer. Legal is what I'm supposed to do it. But because the question is so fascinating, I'm taking my time to address it. Legal, don't query me for shoving into my time. So we are, that one program is not thrown away, but mechanism to, somebody has asked mission of the WHO in Nigeria, what are we going to get? You see, so many things can be gained. The WHO is the international body that is assessing performance of health systems. In 2000, WHO ranked Nigeria as 187th out of 189 out of the nation in the world. What is that telling? That Nigeria, if you want a country that has no healthcare delivery system, come to Nigeria. So this kind of programs, this visit of Nigeria and visit by the WHO will now begin to change the narrative of Nigeria among community nations. That is number one. Number two, they are come to, if you do carrots, people tend to do more. If you do stick, it will serve as a deterrent. So I think by the time the WHO, despite all the things that is happening in Nigeria, begin to say that the health system in Nigeria is in the right trajectory, it will push smart. And thirdly, they have reservoir of technical capacity. We have collaborated with the University of Mahidol, fully funded PhD program on health technology assessment, and the 3 of our staff have been nominated for that. Next year they will give us another 3 PhD slots. Another year they will give us until 5 years. So we are going to have about 15 PhD or people that have competence in epidemiology, competence in data science, and competence in health technology assessment, of technology assessment in Africa. So these are some of the benefits. I'll talk about also quality of drugs in the market. Number 2, to ensure that all the drugs that are coming in the health insurance ecosystem are of quality. Number 3, to bring down the costs. To bring down the costs. We have done everything. We have gotten ministerial approval. What is left is now to get a drug management organizations that will start anytime from now. The system will be kick-started. And once it kick-started, we are going to be having drugs like the major complaint if you go to NHIA. Somebody will come, they will give him anti-malaria in the name of Roche or in the name of Sweeper, depending on how those companies have named it. In the pharmaceutical industry, once the drug is branded, the cost of that drug multiply 3 times because of branding. Just by branding. And no matter how much you will try to educate people that look, this unbranded, they are same chemical concentrates. They will not listen to you. And the media will not help you to do that advocacy. To tell Nigerians that these drugs are the same. So, since you are not
that we now put our thinking cap to bring manufacturers, launch corp. People have confidence in your company. This company come. We want you to manufacture a drug, but you will put NHIA. It's branded. And this branding is NHIA, the organization that is sending you. Will you come and tell me that that drug is not good? No. If you come and tell me that that drug is not good, I will tell you that this drug is manufactured by Roche. This drug is manufactured by Sweeper. This drug is manufactured by a right company. So ladies and gentlemen, this is how far we have taken NHIA. And with all these ingredients we put in place, and now the mandatory law has been assented to, the journey for universal health coverage is now on course. Thank you.
I thought the Honorable DG would get a standing. DG, sir, we've also circulated the gift sheet pamphlets to everyone in the room, and we have our branded T-shirt. Talking about branding, we have our branded T-shirt for our colleagues in the media. So we'll ensure that this go round. So thank you very much.
You have the branded logo. The branded National Health Act. Please go and get them the branded National Health Act. Yeah? No, after. So, please, Hajia, go and get them the acts. Gazetted, branded. Okay, so it's time for